936 on WSJS. Dr. Chris Jew is here from Digestive Health Specialists, and Dr. Jew and I were talking off there. We're going to talk about something that is not exactly dinner conversation, and I hope that you're through with your cornflakes this morning before we talk about this. But we're going to talk about something that affects a lot of people, and that's hemorrhoids, right?
That's correct.
All right, before we get started, we have all seen Preparation H commercials, and I think that's our standard for what a lot of people know about them, but it can be pretty serious. So let's talk about them. There are different types, and we need to understand that if we're being bothered by that, right?
That's true. Hemorrhoids are very misunderstood. Whenever anyone has symptoms of pain, bleeding, itching, something that feels not right down there, we all assume it's hemorrhoids, but that's not often the case. Hemorrhoids are very specific parts of your body that are actually normal, and you only have issues with them when they become abnormal. Okay, two types that you have are internal hemorrhoids, external hemorrhoids. Okay, they both can present similar symptoms. Sometimes bleeding is more predominant with the internal ones, although you can see bleeding with the external ones as well. Pain, usually more with the external ones. But if you have any of the symptoms that were mentioned, bleeding, pain, itching, it's best to see your healthcare professional to make sure that they are only hemorrhoids and not something else more worrisome.
Because this really can be. You were telling me people say, well, that went away. But maybe that's even worse because you don't know what the problem is, right?
That's true. Often that can delay diagnosis of something more serious. Bleeding, anytime you see blood, not in your blood vessels, but on the toilet paper, in the toilet bowl, it's worthwhile to see somebody to be evaluated. Things that could it be: anal fissures, cancer, fistula, other skin diseases, melanoma, Paget's disease, other things that won't be treated with just your over-the-counter Preparation H.
Bad things all the way around, either way you look
That's
at it,
true.
right?
Yeah.
Yeah. Now, there are two types. Let's talk about the difference.
So your internal hemorrhoids have a slightly different blood venous return than your external hemorrhoids. Internal hemorrhoids can be treated usually with dietary modifications, changes in your toilet hygiene. What I mean with that is most people who do have hemorrhoids, they're brought on by conditions with increased intra-abdominal pressure, such as obesity, weightlifting, sitting for long periods of time, constipation, diarrhea. Treatments for those usually are increasing fiber in your diet, losing weight, increase your activity, and fixing what the underlying problem is for your constipation or diarrhea. We recommend patients who spend a lot of time on the toilet, who have their iPad in the toilet, who have their newspaper in the toilet, to move those items out of there so they don't spend more than about 5 minutes in the toilet. And if you sit on the toilet more than 5 minutes, set a stopwatch. When that stopwatch goes off, go do something else and come back later when you really need to use the bathroom.
There are a lot of people that do that, though, aren't there? I never have been one to do that, but there are a lot of people that do that.
I'm guilty to have some magazines, golf magazines in my toilet area that my wife doesn't care much about.
Well, we actually have a guest that comes on with us every year. There's a series of books called Dr. John's Bathroom Reader, and that's what it's for, because they're little short segments that you can read in there. I get, and they've always, it's, kind of trivia style things, but that's what it's for. It's because so many people do that, but it's not healthy.
It is not healthy at all. And sometimes making these small changes, increasing the amount of fiber in your diet, not sitting on the toilet for too long, can make these symptoms go away if they indeed are hemorrhoids.
Now, let's talk about external ones.
So external ones, they have like I said, a different vascular return. And so they are treated a little bit differently. Oftentimes, people come in and see us with external symptoms when they become thrombosed. What that means is a clot enters the external hemorrhoid and is stuck. It's very painful. And in order to treat that, it's either you wait it out, lasts for about a week to 10 days, or you see usually a surgeon who can lance the clot and remove it, and you will have instantaneous symptomatic relief.
I've been there a number of years ago now. Been there, but you're right. I mean, you are hurting it, like even when you walk, and then suddenly it's gone. So
People can't think straight when they have a lot of pain down there.
that's right.
They can't focus on the job at hand.
Oh, that's for sure. Well, it's good that they're now. Do we ever deal with? Can this ever be severe enough that actual surgery? I mean, put to sleep surgery is an issue.
In the past, all we had was surgery for when hemorrhoids became very symptomatic. There are different grades of hemorrhoids, grade from 1, 2, 3, 4, and it's all based on your symptoms, whether they prolapse, you can push them back in, or they stay out. When they get to the stage 4, where they're always hanging out, then you need to see a surgeon to have them treated. Between the stage 2 and 3, there are other techniques now that are less invasive and almost pain-free, I want to say, which we do in the office, called rubber band ligation, using the CRH O'Regan system. And pretty much everyone has 3 hemorrhoids. Some can be bigger than others. 2 on the right side, 1 on the left side.
Now these are natural. We all have them.
These are normal, yeah. But when the ligaments that hold the hemorrhoids up fail us, or they become engorged with blood during a flare due to whatever underlying disease is promoting it, then we would need to treat these. And the rubber band ligation entails very few things. You don't have to take a preparation. You don't need sedation. Pretty much there's a syringe-like device called a ligator, which we put a latex rubber band on. We suck the tissue, excess tissue above the hemorrhoid in there, and deploy a band, which cuts off the circulation to that tissue, forms a scar, which holds up the prolapsed tissue, and obliterates the blood flow to the hemorrhoids. Usually that's for internal hemorrhoids, but it can have some effect on your external hemorrhoids as well.
Do we have to have them? Is it? I mean, it's natural to have hemorrhoids, but can we do without them?
Everyone can do without symptomatic hemorrhoids. When they become difficult to maintain with just conservative measures, that's when you should come see your primary care or gastroenterologist to see what modalities would be best to get rid of them, whether it be topical medications, rubber band ligation, or to see a surgeon for hemorrhoidectomy. Now,
when we talk about this, the treatment has changed considerably in the last few years for it. I mean, a lot of people used to have surgery was just the way, but you're talking about is something as simple as changing your diet.
Yeah, people don't have enough fiber in their diet. You need at least 25 to 30 grams of fiber, and how much is that? An apple has about 3 grams of fiber. Your bowl of cereal has about 5 grams of fiber. When I talk to patients and just go through their food diary and say, so what did you eat last night? Oftentimes it's, I had some chicken, had some rice. Yeah, that's about it.
No fiber there.
Yeah, and then you'll ask them about their lunch. They go, I had a sandwich, cheese, and roast beef. And then I'll be like, so when did you have your fiber? And not all fiber comes in just foods. You can take supplements. There are gummies, powders, and other things like that you can take to meet your dietary fiber requirements.
I heard once that one of the problems is, or one of the good things is, Europeans are much better at fiber. That's much more part of their diet than Americans.
Europeans have a smaller diet, it seems, and they have more fruits and vegetables in their diet. Meat is more expensive in Europe. The only health downside in Europe is they seem to smoke a lot more.
Yeah, they do. Everywhere. They haven't got over that, and that's for sure. We're going to take a break, and we'll come back and we'll talk some more with Dr. Chris Jew from Digestive Health Specialists. It is 9:46. 9:48 on WSJS. Dr. Chris Jew from Digestive Health Specialists is our guest, and we're talking about hemorrhoids. As we said when we started, not necessarily a typical dinner fare, but it's certainly something not to be ignored. If you're experiencing pain, how does it work to get something treated? Start with primary care physician, I would imagine.
First thing is to pick up the phone, call your doctor, and be seen. If you have a gastroenterologist, see your gastroenterologist. And usually in the history of patients describing their symptoms, we can kind of pinpoint whether or not this may be a benign or not worrisome thing, or it's something that requires more workup. And usually we'll have a physical exam, which a lot of patients do not enjoy. The digital rectal exam, examine the tissue outside the anus, and then usually there's a finger inserted into the anus to check the anal canal and the distal part of the rectum. And hemorrhoids, if they're big, can sometimes be felt, but hemorrhoids flare, and when they're not symptomatic or large, sometimes they can be missed. The rectal exam also helps us look for anal fissures, which can give symptoms similar to the hemorrhoids, such as the pain and the bleeding, but they're treated completely differently than you would for your hemorrhoids. Usually when patients come see us and they see blood in the stool, like I mentioned before, blood outside your blood vessels is not normal. We usually recommend a visual or endoscopic inspection, either with anoscopy, which can be helpful if you're familiar with how to do it, but nowadays we're trained in a way to use our endoscopes to look and evaluate. And sometimes a simple flexible sigmoidoscopy, which is pretty much half a colonoscopy, or a colonoscopy if there's some more concerning symptoms, would be very helpful in visualizing, seeing how large the hemorrhoids are, or if indeed they are hemorrhoids and it's not something else like a rectal cancer, large colon polyp, or anything that requires different types of management.
And it goes back to regular as needed 5-10 years depending on your history for colonoscopies. I mean, that's still the
colonoscopy is all based on risk factors, personal risk factors. Have you had polyps before? Family risk factors. Do your first degree relatives, brothers, sisters, mother, fathers have any issues with polyps, colon cancer, and usually age of onset of colon cancer. Anything below the age of 60 is when you are at the high risk. And sometimes these things are difficult to figure out yourself. So again, the best thing to do is call your primary care doctor or your friendly neighborhood gastroenterologist to figure out whether or not you need the procedure done or not.
Well, and there again, I mean, this is a little off the subject of this, but there again, that is a whole lot easier than it used to be. That has really advanced that test, so it's not near as debilitating, maybe is the best word for it.
The prep hasn't changed very much, and that's still the toughest hurdle to get over. But nowadays, the advances in sedation, most practices, and our practice has moved towards anesthesia-based sedation, getting propofol, which is a fast-acting anesthetic agent, and patients come into the room, we talk for a little bit. When they're ready, they get the medication, they feel a little warmth in the arm, they start talking for about 2 seconds, and then they fall off to sleep, and the next thing they know, they're in the recovery room and asking, are we done?
When you're going to start, right?
Yeah, exactly. When are we going to start? So,
I know the last time my wife had one of those, I was ready to take her home and put her to bed, and she'd had one before, and of course I've had a couple of them over the years, and she said, I said, well, I'll take you home, we'll get you something to eat. Let's stop at a restaurant. I'm hungry. You know,
right.
I was just amazed at how quick now you can come back, that you're pretty much back to normal, as opposed to having to crash the rest of the day to get over the anesthesia from that.
That's true. Before we used to use a mixture of benzodiazepines and narcotic medications, which have very long half-life and kind of linger in and give you symptoms of nausea and just not feeling well and fatigued throughout the day. Nowadays, people are asking whether they can go back to work.
Yeah.
Can I ride the tractor today? Things like that.
Right.
And we always warn them, you may feel well now, but, the medicine still kind of lingers and you're not 100% yet. So we always wait till the next morning before we tell them to do anything.
Well, I think the most important thing out of this discussion is to remember that you may think it's hemorrhoids, but it's not always. Boy,
it's not always hemorrhoids. That's the big take-home point. Bleeding, itching, burning, tissue down below in the anal rectal region. Yes, most of the time it is, but for the times it isn't, that's when it's important to be evaluated.
And I think for lots of people, if you are concerned about your health, I think one of the scariest things is blood in your stool, because that really means that there's something going on inside that you need to have something done about. It is not going to go away necessarily.
Yeah, I don't want to sensationalize this, but Recently, we've seen people in the office, or I saw a patient in the office in his mid-50s who was complaining of seeing blood in the stool for a few months and just kind of wrote it off to hemorrhoids. Did a rectal exam and something abnormal was felt, and we scheduled for a colonoscopy and actually found that they had rectal cancer. And when we find that, it saddens me that 5 years ago, if he had come to the office to have his screening colonoscopy, that cancer may have just been a large polyp that could have been removed, and that would be the end of that. But with cancer, it's more involved. You require some radiation and then eventually surgery to get this taken care of.
But he could have done it a lot just by not writing it off as
colorectal cancer is the most preventable type of cancer that we have. We know that colon cancer starts off as small growths in the colon called polyps, and once they're removed, your risk of developing colon cancer drops down dramatically. And routine follow-up is necessary, but it's probably one of the most effective ways to prevent cancer that we have.
And make sure that's what it is. I think that people hear about hemorrhoids. I was surprised that 10 to 25% of the population has it.
The incidence of symptomatic hemorrhoids is about 10 to 25%, but like I said before, everyone has hemorrhoids to a degree or not. It's just the vascular cushions that are in the perianal region.
And so, but we can do something about it. And the key is eat more fiber, probably as much as anything else, right?
Yeah, lifestyle modifications, high fiber diet, heart healthy diet, not too much short rib in your diet.
Well, that sounded good, though,
and,
didn't it?
and actually, oh yeah, that sounds great.
Short ribs would be good, but we are. It's nice when you start. When I got serious about my weight and my diet, when you start thinking about what we eat on a normal basis, it's no wonder that it is a wonder that we don't have more health issues in our digestive tract.
Well, I guess I have a biased point of view, but I get to see a lot lot of that day to day.
Yeah, it's your job. Doc, pleasure to have you in this morning.
Thank you
for
so
being
much.
with us. Digestive health specialist, our guests, and we'll have some other subjects. But today, Dr. Chris Jew is talking about something that now you've heard about it, and you don't have to discuss it at dinner tonight, but certainly make it a part of your concern for your health, right?
Don't be embarrassed. Talk about it. It's normal.
That's right. That's going to do it for us for today. Have a great day. We'll see you tomorrow morning right here on WSJS. It's 9:57.